My name is Josh Rosenblatt, and I just want to start off with saying that I really, really appreciate it. I know that many speakers have commented, but it really is quite humbling to be here and to be with so many pioneers of ketamine. And I'm someone that's a junior investigator, and it's been more so in the past few years that I've been working with ketamine. So wonderful to see and meet some of the pioneers here. So I'm going to be talking specifically about real-world data within the context of difficult-to-treat subgroups. So we have published quite a bit about our real-world data in general, but specifically we'll be focusing in on these subgroups. Here are my disclosures as most pertinent for this talk. I'm the medical director of the CRTCE, or the Canadian Rapid Treatment Center of Excellence. That's a private clinic specializing in these rapid treatments. So right now we offer 4 treatments: IV ketamine, intranasal S-ketamine, sublingual ketamine, and psilocybin-assisted therapy. I'm also the chief medical and scientific officer of Bractis Scientific. That's a publicly traded company. And so CRTCE is a wholly owned subsidiary of Braxia. So as I mentioned, we're going to be digging into real-world evidence and looking at these 3 specific subgroups. It was a bit difficult actually to decide what subgroups are most important to cover, but I thought that based on the other talks, that these 3 would probably be the most relevant and interesting. I'm glad that to follow Osman's talk and just sort of establish the importance of real-world effectiveness data, and that, of course, we all agree that RCTs are at the top of the hierarchy of evidence and the most rigorous way to test efficacy. But certainly combining efficacy RCTs with real-world effectiveness data is really important, just to get a better sense of generalizability for the patients that we're actually seeing in clinic. At our clinic, we do not exclude complex or difficult to treat patients. So ultra-resistant, ECT resistant, medically complex. For example, we have many transplant patients that come to our clinic, and we still provide treatment, actively suicidal patients. And this is actually a slow side thing, not your typical RCT candidates, where I think in this past week, we've seen that a lot of clinical trialists are becoming quite courageous and including these more complicated patients in their trials as participants. So I think that perhaps the gap between real-world effectiveness and efficacy in these RCTs is going to become narrower as we start to include these real-world patients in our clinical trials as well. We do have sort of open ethics approval for analyzing our data in a variety of ways, and we are registered on clinicaltrials.gov as well. So to start off, just a bit on the eligibility criteria for our clinic. So we do exclusively provide it for treatment-resistant depression, but we include both bipolar and unipolar depression. Certainly patients come with lots of comorbidities, but I'm very clear with them when I meet with them that if your primary goal is to improve your anxiety or to improve your PTSD, that's not really our primary goal or what the evidence primarily supports, even though certainly with PTSD, some growing evidence in anxiety as well, but very clear in the informed consent discussion that we're really primarily targeting the depressive symptoms and suicidality as well. We do have the standard threshold of 2 or more adequate trials during the current episode, and we do a fairly thorough assessment to ensure that they actually were adequate trials. So certainly someone on a day of an antidepressant that developed anxiety would not be considered adequate. For our patients that are chronically depressed and we can't really delineate the current episode, we say in the last 2 years, they have to have had at least 2 recent trials. These are the key exclusion criteria. If they're medically unstable, if they have uncontrolled hypertension, nothing really surprising here. If they're not able to adhere to the protocol, pregnancy, there has been a couple exceptions in consultation with peripartum psychiatrists where we may actually be providing it in pregnancy with ample informed consent. And certainly if they have a current or active substance use disorder. Importantly, comorbid personality disorders and active suicidality are not contraindications. Just another sort of mention that this is the eligibility criteria, meaning that this is black and white. If you do not have treatment-resistant depression, we are not able to provide the ketamine treatment for you. That being said, we also have a long discussion about suitability. So I think the comment has been made several times that if your patient has tried escitalopram and sertraline, this isn't a great candidate for ketamine. It's probably a good idea to try other things. So every patient that comes to our clinic would have a full psychiatric assessment and would have a discussion about other alternatives, ECT, second generation antipsychotics, psychotherapy. So for myself, it's typically 80-minute consultations where these are very complex patients. And I want to make sure that we're not just a ketamine clinic, that if you come here, you're getting ketamine, but it's very clear that this is one of the options, but there are several other options. I work at the private clinic, but I also work at an academic hospital. So sometimes I might say to the patient, come to my side of the academic hospital. We can give you psychotherapy that's covered through philanthropy. Do that first, see how you do. We'll try some medications. And if that's not working, we can revisit ketamine. At the same time, I strongly believe that eligibility has to be black and white. If a patient has only had 2 antidepressant trials, they hear the whole discussion and they still say, I want to move forward with ketamine, I would say you're eligible and we'll support you through it, even though there's these other alternatives that, in my opinion, I think are probably better at this point. So that's kind of the context for how we assess the patients. So this is the acute treatment protocol that we use, where it's 4 doses over 2 weeks, so fairly similar to other repeat dose protocols and what we've seen in the clinical trials. We do have the option for a dose increase. However, I would say it's a fairly conservative way that we do it, where if the patient shows 20% or more reduction on the QIDS, we would not offer them the dose increase. So in 20%, it's fairly small amount. So if they're showing any signs of improvement, we're not going to increase it. We're going to stick with the most studied and evidence-based dose of 0.5 milligrams per kilogram. But if they're really showing nothing and they tolerate it okay, then we will offer the increase. Sometimes we go slower. We might go to 0.6, but most commonly we go up to 0.75, and then that's what they would receive for the 3rd and the 4th dose. And of course, we could reduce the dose if there's an issue with tolerability. Before they start this, they would receive, again, a full psychiatric consultation. We do not accept self-referrals. And on the referral, we actually specifically ask for the referrer's opinion in terms of, are they on board for this? Are they actually against it and feel like ketamine is not the right option? Or are they prepared to be fully engaged in the care, where we're not able to have the capacity to make them our patient and become the MRP, but we can provide this specific part of their care in combination with everything else that they're receiving. So we assess the eligibility criteria, and then as they go through, they would be having measurement-based care that's connected with our REDCap platform. And for those of you that use REDCap, you'd be familiar that it's very easy to use, both from a user perspective for the person answering the questions, from a staff perspective, and from a research perspective, where we can very quickly do an analysis where in an afternoon I can extract our data for patients up until yesterday and do an analysis. So very convenient to do these sort of live analyses with ongoing research questions. So this is really the infrastructure that we're trying to build with our clinics, where we strongly believe both in RCTs and real world effectiveness, where the idea here is that we want to always be providing the most up-to-date, evidence-based, gold standard ketamine care in all of our clinics. We have 4 sites right now. We want to collect the data very carefully to see how our patients are doing, and then also use that as pilot data to propose new hypotheses. We use that pilot data for grant applications, and then hopefully and thankfully have received a lot of funding to do RCTs. And then we conduct the RCTs both at our academic sites, since as a private clinic, we're not able to apply directly for federal and provincial funding, but we would be sort of the primary sites where we're still doing it in the hospitals, but also at our clinic network as well. Once we have the results for the RCTs and the real world effectiveness data, the plan is to, we translate to the findings that are just kind of round and round we go, where we try to be most up to date, both contributing to literature as well as using the literature at a rapid pace. And so just to have that agility to kind of implement changes fairly rapidly. So here's our data for the first 300 or so patients that came through. So for these patients, these are primarily my patients. When we initially started, I was the only psychiatrist for a full year, and it was quite a lot to see all these patients, but it was a choice that I made as well, just from the perspective of wanting to have that not just knowledge from a research perspective and from reading literature, but to have personally treated hundreds of patients to have that firsthand experience. That was a decision. But right now, as we've expanded and we've treated a lot more patients, we have about 20 psychiatrists a dozen anesthesiologists and about 50 nurses. So it's expanded quite a bit, and it's really it was still really helpful to treat those patients my own. But just kind of an asterisk here, these are primarily my patients actually. A fairly similar breakdown compared to previous studies that we've seen, where interestingly there is more male patients than we typically see in a depression sample, primarily unipolar depression, but 14% with bipolar depression, and quite resistant, with a mean antidepressant trials of 6 plus or minus 4 with the standard deviation, and then most people on 1 or 2 medications when they're starting their treatment. So I won't spend too much time on this. This is something that we published a year ago based on the first couple hundred patients coming through our clinic. It does map on quite well to the data from OSMIND, so that's encouraging to just see that sort of replication, where certainly we are seeing clinically and statistically significant improvements on the QIDS, on the suicide item specifically, some improvements on the GAD-7 as well, and as Roger presented in a bit more detail, I believe improvements on the functional scales of the Sheehan Disability Scale across all 3 domains of work, social, and family. So certainly that could be a whole talk on its own in terms of the overall sample, but I really do want to focus in on some of these complex subgroups. As an aside, some of the patients in our sample were treated during the pandemic, and this question came up a lot, where patients would say, should I actually hold off on having my infusions because I'm worried that is it really going to work if I still can't see my friends and family? And certainly, especially in Ontario, where the clinics are, we've had very strict restrictions where for a very prolonged period of time, people were having almost no in-person interaction. So this question often came up of, will ketamine still have the same effects if I'm not able to kind of implement the benefits that I've had into the behavioral activation for doing things? And what we found, as you can see in the A figure there, the lines basically perfectly line up, where when we look at the 1 year before COVID compared to the exact same year during COVID and during these restrictions, there was no attenuation of the antidepressant benefits. So we still include them all in the same sample right now and don't separate them as such. So, this is the big question that often drives me to do this subgroup analysis that comes up time and time again, where, I spend 80 minutes with the patient and the patient says to me, doctor, have you seen ketamine work for patients like me? You seem to know me well right now. You know my history. You know that I've failed ECT. I have borderline personality. I used to have an alcohol use disorder. Do you think this is actually going to be helpful for me specifically? Have you seen this help for others? So that's really what drives us to do the subgroup analysis, where we can essentially operationalize the clinical experience that we've had in a data-driven way, so that we're not just shooting from the hip and saying, oh yeah, I've seen this work for people like you, but we can actually say that in a data-informed way. So these are the 3 specific subgroups that we'll talk about, starting with bipolar depression, which I think by this point is probably the least controversial, where bipolar depression has been included in a lot of the more recent studies. So this was the sample that we had of 66 people. And one of my master's students, Farhan Fancy, has been digging really into this data, and we hope to submit the paper very soon, but this is actually unpublished data at this point. So here are the demographics, and similarly, you can see a fairly treatment-resistant population with around 5 or 6 failed medication trials. We include both bipolar type 1 and bipolar type 2. They just can't have current acute psychotic features at all. As presented earlier, the primary RCT data for bipolar depression is single dose studies. So Carlos Oretti studies and Michael Grunbaum studies showing that a single dose seems to have some benefit with it, but none of the serial RCTs where you have repeated ketamine infusions, where there's always this question of, certainly for major depressive disorder, it seems that serial repeated ketamine infusions is more beneficial compared to a single infusion, but hasn't really been demonstrated for bipolar depression. And then there's this question about safety. Are we going to trigger manic switches similar to exposure with some antidepressants? So thankfully, we had fairly encouraging results where we saw a signal of improvement, but we also saw a very similar incremental response with further improvements with serial infusions. So with 4 infusions, gradually having an increased response and remission rate. So response rates getting to almost 50% and remission hospitalization rates getting to around 30%. I'm not showing it here, but certainly the suicidality was dramatically improved as well. We did have 3 hypomanic switches, none with psychotic features, no full manic switches, no hospitalizations, suggesting about a 5% switch risk. And in the single dose studies, it seemed to be around 2%. So perhaps there is a bit of an increase in manic switch rate with repeated infusions, which just kind of intuitively makes sense. What's really interesting, what Farhan found was there did seem to be a trend for greater improvement with bipolar II depression. Certainly with bipolar II disorder, patients spend more of their lives in the depressed state. And so bipolar II depression is certainly a huge, great need for new treatments where treatment-resistant bipolar depression is kind of the norm for bipolar II disorder. So there was a trend for further reduction in symptoms for bipolar II depression. However, when we corrected for baseline severity, it did no longer reach statistical significance. So something that still is an interesting question to be tested, but we don't have statistical evidence to support that it's actually clinically or statistically significant difference between these groups. This is much more preliminary. This is our maintenance data, which gets really messy because patients have variable reasons for stopping treatment or spreading treatment out, often driven by financial reasons. If, for example, the insurance says we're only going to pay for the first 4, or we're only going to reimburse you 50%. So this is a big part. Sometimes patients not being able to get rides every week and things like that impact the optimal frequency of booster infusions. But what our preliminary analysis has suggested is that after getting the twice-weekly doses, most people with bipolar depression seem to do fairly well on around the every 3-week frequency, and that's able to maintain the benefits fairly effectively. So there's this provocative question of, could ketamine actually be a mood stabilizer? And certainly something about bipolar disorder with, the role of glutamate, and we think about lamotrigine and these other sort of glutamate modulators, where we wonder if targeting the glutamate system might actually be optimal. And certainly there is some data to suggest that bipolar disorder might be a predictor of better response compared to unipolar depression. So really important to study it in that group. We did this analysis actually using our full sample last year, looking at agitated depression or depression with mixed features, specifically using the AIA criteria, which is a well-defined and validated criteria, looking at agitation, irritability, and anxiety. So certainly this group often being less responsive to treatment in general, but as it pertains to ketamine, they seemed to be equally responsive, and there actually seemed to be a bit of a trend for greater responsivity in this mixed depression population, which was interesting. And while this is, including everyone, in the 16 participants with bipolar depression with mixed features, in that group, I found it to work even more effectively. So in many ways, that seems to be a positive predictor, interestingly, rather than a negative predictor. So to summarize the piece on ketamine for bipolar depression, the real world evidence is fairly encouraging, suggesting that it somewhat lines up with the RCT evidence. And as I showed in that sort of initial cycle figure, we have been able to obtain funding now to test this in clinical trials. So we're doing a 100-person clinical trial for the first part in terms of the repeated 4 infusions, and we're controlling with midazolam, and then we'll have a maintenance phase as well. I think that the funding that we've received has been very encouraging from the perspective of how effective this approach can be, where I'm, very transparently a junior investigator, and these were all the grants I was submitting in my first year. I finished my master's in 2020 and submitted a bunch of grants, and we've gratefully, had a 100% success rate. I think because of the pilot data, where we've gone 5 for 5, and we're doing a lot of research right now, and certainly having the team, the mentorship, and being an obsessional perfectionistic grant writer is important. But I think the pilot data really is what sets things apart, especially as a junior investigator, where often the comment is get some pilot data, but you don't have funding to get the pilot data. But here we can kind of get it for free, so to speak. So very excited that we're starting recruitment this month for these trials. trials, and they're fully approved after much delays. This is just sort of what it looks like for the KET-BD RCT, where we're going to be doing a lot of measures. We're going to be looking at some blood biomarkers, and we really want to very carefully characterize the safety, the tolerability, as well as, of course, the efficacy for ketamine in this group. So this will be the first, to my knowledge, repeated dose ketamine RCT in bipolar depression specifically. Here's the add-on study where we'll be offering maintenance, and we'll be doing this for 12 weeks after the acute course. So the next group, and there was several, I think there was a few questions about this earlier, so glad to share this this research with you. So how about in these ultra-resistant patients that are also refractory to ECT? Should we bother? Is it worthwhile to still try ketamine, or is it kind of a lost cause? So Nelson Rodriguez, who's one of the most gifted research coordinators I've ever worked with, led the analysis on this, and found some very interesting results. So to start off with the demographics, fairly good sample sizes where over 100 of our patients actually had a history of neurostimulation, being rTMS, ECT, or both, compared to the neurostimulation naive participants, which was 135. So fairly similar, except for one key difference right here, with mean antidepressant trials of 8 rather than 5. So clearly, these are not, just neurostimulation refractory, but it's more of this indicator that this is an ultra refractory group. So what we see here, if you look at figure A, is that no asterisk. So there was no statistically significant difference between patients that had neurostimulation versus patients that did not, but you see a trend. So the green line is the history of neurostimulation, and you see there is some separation there, even though not statistically significant in a fairly large number of participants, around 100 versus 100, we do see a trend, and that certainly matches up with what I've seen clinically, where it's a soft predictor, where I am a bit less hopeful, but I don't say to patients that it's a lost cause, because certainly I've seen a lot of patients that have had ECT that didn't respond and had a very good response to ketamine. I should mention as well, I'm an ECT provider, so I do go through the notes and see how adequate was the ECT, and often if it was 1 or 2 treatments and they were tolerating, okay, the suggestion is, well, do you want to just go finish your ECT first? So so that's an important piece too, that I think these were genuine rTMS and ECT trials. So encouraging to see that it still seems to be worthwhile to try for ECT refractory or neurostimulation refractory. The question often comes up that rTMS and ECT are very different, which I agree with, but there actually wasn't a big difference in terms of it seemed that the group of neurostimulation refractory kind of grouped together, where the lines are pretty much indistinguishable, where failure to rTMS or ECT was similarly a slight non-statistically significant negative predictor of response. The last group that I'm going to present on, and this was actually thanks to Rupert's question that there was interest in this. So this, again, with the REDCap database, being able last week to pull the data and analyze this interesting question that you had, looking at patients with comorbid borderline personality. So, being in a TRD clinic, a lot of the time, my colleagues joke and say that it's a borderline personality clinic, and there's this assumption that everyone with TRD, everyone that's chronically suicidal must have borderline personality. But, I hope that most of us in this group can agree that that's not the case. And so we have been using the McLean screening instrument, which is a very well-validated instrument with good sensitivity and specificity, using the threshold of 7. And we found that 20% of our sample had, over 7, suggestive of borderline personality traits or disorder. So we had 55 participants that we could analyze to see if it's still working well in these groups. I should mention as well, we are very explicit with patients that this is for your treatment-resistant depression, where sometimes patients come to me saying, I have treatment-resistant borderline personality, I want to use ketamine for that. And I'm very clear with them that we're targeting the depression, we're targeting the suicidality. This may or may not help with your borderline symptoms, but we don't have evidence to really support that at this time. So, as we grew the number of psychiatrists in our group, I'm mindful that we all have biases and things like this. So this slide is actually part of the training that we have for our psychiatrists, where unfortunately, there's still so much stigma against this diagnosis. People saying they're not actually depressed, they're so cluster B, they just need DBT. You know, with our treatment being a fairly expensive treatment, large majority of people have already had residential treatment, DBT, and they sort of had it and it's failed. And you know, this comment that I've heard, unfortunately, and it makes me very sad, this idea of meds won't help them, nothing will, where there's just kind of this nihilism that nothing can help these patients. So I'm a strong believer that denying patients of ketamine or antidepressant treatment who have true TRD is discriminatory and not evidence-based. That's why we do not have it as an exclusion criteria. And now we actually have some reasonable evidence to show that, you know, there's almost a 10-point decrease on the QIDS. And if we think about the Osmind data, for example, where there was a 6-point decrease on the QIDS. So, you know, certainly in that range with, exactly 8-point decrease that we observed here on the QIDS SR. And we did see incremental improvement with each infusion. We're also seeing improvements on anxiety. And certainly in this group, there's often very high comorbid anxiety where that triad with anxiety, depression, ADHD, borderline personality that we often see. So it does seem to be helpful in both of those. Using the short form self-report of the Columbia, this is a 6-point scale. We did see fairly significant reductions in suicidality, which I think, of course, is top of mind and is often the primary outcome in a lot of research, in a lot of clinical trials in borderline personality. So there's this interesting question also of, what if someone has borderline personality and suicidality but doesn't have depression? Could this be helpful for their suicidality, since there's some mood-independent anti-suicidal ideation effects that have been shown before? We have not done the path analysis for our data to see if there is mood-independent effects, but my general impression is that for some people, they have had reduction in their suicidality to a greater degree than the reduction in their depression. Functionally, there's improvements as well. So not in the workplace, but social and family. And these are the, you know, functional domains that are most often dramatically impaired, you know, especially social domain. So seeing some subjective functional improvements in the social domain as well. This one's really interesting. So improvements in anhedonia and numbness being sort of one of those core symptoms, and patients telling me that they feel less numb. And this quote from a patient, I truly feel for the first time in years. And just this idea of, you know, these patients that have been numb through their borderline personality, and often more blunted through their antidepressants and antipsychotics, but then for the first time being able to experience their emotions, which, you know, is quite cathartic and a positive, even when negative emotions come up on patients' qualitative report. This is the most interesting, I think, and perhaps the most controversial. So can ketamine actually help with core borderline symptoms? So the BSL-23 is a popular 23 item questionnaire where you rate from 0 to 4, and then you average the responses for all 23 questions. So the end is a scale of 0 to 4. So at baseline, this group of 55 scoring 2.2, and after 10 days, after having, you know, 3 infusions, that reducing to 1.6. For myself, you know, we selected the scale based on some collaborators that specialize in borderline personality, but I wasn't as familiar with it. But taking a look at the literature and the initial validation study, it's really interesting to see that our improvements in 10 days is similar to what we see with dialectical behavioral therapy. So we see with a 12-week DBT program decreasing from 2.25 to 1.82. So in fact, even perhaps a slightly greater improvement in borderline symptoms. So, you know, quite encouraging. And I would not by any means say that ketamine is a treatment for borderline personality, but it makes me wonder, you know, with these DBT programs, we're often patients get worse before they get better, and there's this sort of a delay period, understandably, you know, maybe, and this is certainly, you know, an RCT that I'm working in developing right now with some colleagues, could be combined ketamine with DBT so that you get rapid reduction of borderline personality and suicidality, and then you get more maintained effects from the DBT over, you know, 12 to 24 weeks, whichever protocol you're deciding. So very, very exciting that, and you know, phenomenologically, I think as well, when depression is the stressor that's driving the disorganized symptoms that we're seeing, when we remove that stressor of the depression, it's amazing how much the borderline personality symptomatology improves as well. So to summarize, the real world data certainly is encouraging, even in these subgroups. Certainly lots of limitations with real world evidence, private clinic, placebo effects, expectancy bias, uncontrolled, all the things that we've heard of before. But I'm a strong believer that we can combine this with RCT data, and ideally in the same setting. So I very much appreciated the presentation from the Netherlands, looking at real world evidence as well as RCT evidence in the same clinic, and looking at a very similar context. So I think that's where we can have some really strong data. A number of projects ongoing and upcoming, and what's been great this week as well is to see this push past proof of concept where we are having bigger numbers, and that's certainly what we're doing as well. I know there were some questions earlier about pharmacogenomics as well, so we've genotyped 85 of our patients and done a more deep dive characterization of trauma and all these things. So we're doing that analysis. I mean, spoiler alert, it was unimpressive and unremarkable, where the common suspects based on metabolites were not that impressive in terms of the effect size. So it doesn't seem like pharmacogenomics will be a great way to categorically predict who's going to respond, which is probably not surprising to most people. We are looking right now at psilocybin-assisted therapy for treatment for ketamine-resistant depression. And so right now I've treated about, I think we're at 11 participants. Specifically that were ketamine resistant, and it has been interesting where some of them did respond to psilocybin that didn't respond to ketamine. So it's a really interesting testable hypothesis in that regard, and certainly working on several other projects. Certainly like to thank funders, the hosts of the conference, my mentor Dr. McIntyre, all the students and people working, and last but certainly not least is my wife and new daughter, who allowed me to come to the conference. So she's just 6 months now. I'm very grateful that my mom can help out as well, and my wife is holding down the fort at home. So I'll leave it there and open it up for questions.
Thank you very much. If you don't mind, if I can start a question on my own, that's the advantage of sharing this one. When you were looking at the borderline personality, like things come to mind. What about the self-harming? Did you take a look at that data, and was there any change following the treatment?
Yeah, so the short form of the Columbia doesn't explicitly delineate the self-harm, even though the longer one does. So we don't have that data in the scales, but I can say anecdotally, based on I probably treated about 40 to 45 of the patients in that group, and only 2 of them self-harmed during the course of treatment, and in both cases they were in reaction to fairly severe external stressors. So I don't think we can say that it reduces self-harm per se, but at least it doesn't seem to be increasing self-harm based on our sample.
Okay. I have a question, Esther.
Hi, Esther. Yes, your sample of bipolar depression was quite small, but did you have a chance to look at the different efficacy based on the background mood stabilizer, lithium versus atypical antipsychotic, etc.?
Yeah, it's a great question. We have it. I mean, so we've looked at the data, but the groups are just too small. So not too confident. I mean, basically nothing statistically significant. But like you said, when you have a group of 66 people and you're splitting them up, it just didn't seem to be statistically feasible. Yeah, definitely something that we're interested in. Yeah, thanks.
Any question over there?
It's very, very impressive work in a private population that people are paying. How generalizable do you think your results are to a state-funded population?
Yeah, it's a great question, and I think that could be a limitation of the generalizability, and that's where I think the RCTs are going to be really interesting, where we're doing these RCTs both in patients that were referred to a private clinic as well as patients referred to a public hospital, and so it'll be really interesting to see it. And for those, no one is paying anything at the public or the private sites. It's funded by the clinical trial. So we'll be interesting to see if we see any divergence, because it certainly is a factor. And I think can also have a big impact on expectancy in terms of, if you're saying I'm paying thousands of dollars for this treatment, that sort of increased expectancy of it working. It's a really good point for sure.
Yeah, congratulations, great presentation. So I heard a lot of, concentration on symptoms. So anhedonia, impulsivity, and suicidality, which go really together, I think, and a less concentration about diagnostic categories. So you've got a lot of diagnoses there. You talked about borderline, bipolar, depression, dysthymia. Do you think in psychiatry we're going beyond, the concept of diagnostic categories in general?
Yeah, I mean, that's a great question. So you're asking sort of about just the transdiagnostic approach of not being so focused. Yeah, and I mean, I think that ketamine is really a perfect example of that, where it really does push us to think transdiagnostically. And I think it would really lend itself very well to things like master observational trials and things where we're not necessarily being so stuck with the DSM criteria, but we can think more domain-based, and that was more of what Roger's talk on Monday was speaking to. But very, very much agree. As a clinician right now, I still value the DSM a lot, and it's still the basis that I do all of my work. But I think we do need to push the research to look at things more transdiagnostically and domain-based, for sure. Definitely agree.
Any question, Tim?
Hi. Thank you for including borderline personality disorder. That's really good to see. I was just wondering on the ages or the average age of your patients, particularly thinking that patients with borderline tend to be most symptomatic late teens to up to the mid-20s, and then do get a bit better off. And I was wondering if you noticed any difference in treating younger patients or older patients.
Yeah, so specifically in the borderline personality group, I think it's too small of a sample to really comment on. And you're right that the majority of them are in their 20s and 30s. Although, I still, do see some patients in their 70s with that did not have that self-resolution in their 30s and have been suffering with that chronic treatment-resistant depression and borderline personality. So yeah, I think the sample's too small. Age is a negative predictor, though, and I think that's been shown in the esketamine trials and in our data as well. Older adults had a lower effect size, although still had a clinically and statistically significant improvement. So we published those results in the American Journal of Geriatric Psychiatry, looking specifically at the patients that were older. And I think similar to the Janssen data for patients that had their first depressive episode before the age of 50, that it's more of the sort of chronic lifelong depression. They're the ones that seemed to respond better compared to patients that were older and had their first episode later in life, which often makes you think about, are we talking about the same depression here? So yeah, negative predictor in general in older adults, but I can't comment specifically in borderline personality. Great question.
All right. Well, we don't have any more questions. Thank you so much, Josh.
Thanks, everyone.
Time for some tea.